Good afternoon, everyone, and we are back for the most wonderful next presenter, Miss Ashley Blackmon. We are very pleased to have her this evening as she shares with us information about how to handle COVID and a lot of other issues within the primary care setting. Ashley Blackmon is an advanced nurse practitioner with an advanced heart failure and heart transplant specialty at Piedmont Atlanta Hospital, the Samsky Advanced Heart Failure Clinic. Ashley is a prolific speaker, and she functions and serves as the state vice president for UAPRN. We're so pleased to have her with us this evening, as she is so incredible when it comes to speaking about primary care. We are looking forward to hearing her presentation, and she's coming up next. Ashley, thank you for being here, Ashley.
Thank you so much for that introduction. I'm so excited to be here. This has been a really exciting journey for me, and I'm really honored to be speaking next to these other prolific speakers, so I'm kind of blown away by it. So good afternoon, everybody. My name is Ashley Blackmon. I do have a background in family practice, though I currently spend most of my time with advanced heart failure patients. And so we're going to talk today about COVID-19 care in the primary care setting. So let's go to the next slide. I don't have any disclosures. Next slide. These were the objectives I was sent, which was a little overwhelming because some of this doesn't exist yet, since this is such a new virus. So we're going to go ahead and go to the next slide. So I really appreciate Dr. Del Rio and how he's covered a lot of the pathophysiology already. But what I wanted to touch base on was, though the virus attaches to ACE2 receptors, knowing this pathophysiologically early in the disease, early in the pandemic, we were concerned that the that ACE inhibitors would cause people to be more prone to getting the virus, and other things like NSAIDs, non-steroidal anti-inflammatories such as ibuprofen, and medications like that. So there was a concern early in the pandemic. Now we realize that that doesn't happen. The ACE2 inhibitors don't affect, or ACE inhibitors don't affect ACE2 receptors in the lung tissue, which is the major site for transmission of the virus. Though it does influence ACE2 receptors in the heart and the kidney, and there's still a lot that we don't know about that. But so far, the preliminary data, whether we are aware of the pathophysiology or not, shows that there has been some kind of kidney protection. So we don't change ACE inhibitors in our patients in the primary care setting. But as the virus attacks, it attaches to the ACE2 receptors. There's a breakdown of endothelial and epithelial layers. There's a breakdown in surfactant, which is why you can actually have collapse of the alveoli before you even have fibrosis and scarring. And some patients will even come in with spontaneous pneumothorax before they've even progressed in the disease process. You have pulmonary edema, thickening of the alveolar area, and then of course the coagulation cascade is ramped up in this infection. So a lot of people think of this as almost two infections in one. I really appreciated how Dr. Del Rio was explaining that people, that it's more than a pandemic, that it's affecting, it's really pointing to the breakdowns we have in our healthcare. In the people who are being affected the most by this. And we can see that as there are two phases of the infection. So people will present with an initial viral syndrome, and those who progress to worsening disease can possibly have cytokine storm. All right, next slide. So this is just an illustration of what we just walked through. You can see in the top left-hand picture the ACE2 receptor and how the corona piece of the virus attaches to that, how it enters the cell and then starts to cause breakdown, especially of the tissue layer there on the bottom. And we can, next slide. And then this is progression of the disease. So now you have this influx of monocytes and neutrophils. You have this building up of fluid, and this is actually in the alveolar wall, so where the blood cells go for oxygen exchange in the lungs, and there can't be oxygen exchange because of all this buildup of fluid and cells. All right, next slide. So what are the problems? Well, you have alveolar collapse, you have direct injury, and then you have hypercoagulable state. And this is different from DIC in that DIC, you use up all your clotting factors and then you start bleeding. But instead, you still have clotting factors available. You're just more prone to developing thrombus. And we'll talk about that some more. Next slide. I think everybody at this point in time is aware of the symptoms. Very viral syndrome. There is anosmia or loss of smell, and anguesia or loss of taste. And then everything else can go on even to confusion or chest pain and pressure, depending on the significance of the dyspnea. Next slide. Testing, we have 3 different ways to test people. PCR swabs actually look at the viral remnants. So a person might not have active infection if a PCR is positive. The serum antibody shows that they had an infection, but now they have developed an immune response. And then an antigen test is more of a sign of actual active infection at this time, because it's a whole antigen and not just a piece of the RNA. Next slide. So when we're looking at these 3, the PCR is the nucleic acid test. It does diagnose current infection, but sometimes you can have these remnants left over that can show past infection depending on how much of the viral remnants are available. We're looking at respiratory tract specimens. There's a very high sensitivity and specificity. So false negative rates can be anywhere from 5 to 40%, depending on the test used. And not just the quality of the test, but the quality of how the test is performed. So if actual postpharyngeal sample is not obtained, and it's more nasal or more lower pharyngeal, it might not have the same test results as actual nasopharyngeal. The time to perform the test depends on the test. It could be 15 minutes to 8 hours. Serology is antibody detection. So you have a diagnosis of prior infection, but it could be current infection, but it takes about at least 3 to 4 weeks for your body to build the antibody response for us to see that in your blood. The sensitivity and specificity is highly variable. And antibodies can obviously take weeks to develop. And our tests, right now, depending on the test, there can be cross-reactivity with other coronaviruses. So that's part of why the sensitivity and specificity is questionable. Time to perform the test can be 15 minutes to 2 hours. And we're still uncertain if a positive antibody test means you actually have immunity against future infection. So we're seeing that the initial thought process when we saw patients get sick and then they would get better and then they would get sick again, and both times their PCR would be positive, our initial thought process was, is this virus hiding somewhere and coming back out? Similar to how you see HSV or herpes and things like that, or even chickenpox, how it comes back as shingles, is that happening in the body? But instead, what we believe we're seeing, what the data is showing, is that patients they build an immune response and then the immune response wanes. And so just like over time, we can get a vaccine or get exposed to something, and then years later we can become sick again. because our immune system can't keep that up forever and ever and all time. What we're seeing with this is that we think that the immune response is very, very short, that it's potentially as short as even a few months or a few weeks. We're still not sure. This is still a lot of things that we're researching, but that's part of the thought process behind that. Antigen tests look for diagnosis of current infection. They're also nasopharyngeal or nasal swabs. Data is limited and they're less sensitive than the PCR. So it's important if you're going for a test that you ask, is this an antigen test or is this a PCR test? And then the time is less than 1 hour. Next slide. And so I just so everybody knows, if there's widespread high rates of infection, patients who are symptomatic or presumed positive, even if they've not been tested or have an initial negative test. This is from UpToDate. Next slide. Rural and underserved areas is something I was asked to address, and it's actually just very difficult in general. Patients tend to not have access to a lot of things in rural and underserved areas, especially in the state of Georgia. We're seeing a lot of hospital closures. The availability of PPE has been really stressed. So some of the things to think about is how can people get access to reusable PPE, and could patients get home health with, the people coming to visit have PPE. Telehealth is a major thing. Somebody spoke about it earlier. But you might require a telephone visit instead of a video. Dr. Harris mentioned this, that some people might not have access to broadband or access to internet, and so they might need a telephone visit. It's very important to be able to do a video visit when you can, though. Next slide. So, I was asked to talk about very specific treatment, and there is no single outpatient management strategy. The data is lacking, and treatment protocols are being developed and modified as our understanding of the disease evolves. Next slide. So the keys right now are just to avoid infection transmission. Please wear a mask. Please wash your hands. You need to be singing happy birthday or saying the ABCs twice. You can make it a fun game with your kids. Make sure you're getting under your fingernails and around your wrists. There's definitely an art to hand washing that healthcare professionals developed as habits and skills, but lay people sometimes don't. I was talking to one patient the other day, and I asked him about hand washing, and well, I washed my hands this morning when I woke up, and that was it. So we had to talk about how frequently we wash our hands and when appropriate times to wash our hands, and often it's just some needs to be a habit that's developed for our patients. Remember, we're going to preserve limited resources. So sometimes when we have access to things, we use it, and sometimes we have to pick where we use our resources. Our keys are to reduce burden on the overwhelmed healthcare systems and to have frequent follow-up, very, very frequent follow-up. I think this is something very difficult as an overwhelmed healthcare system for us to follow through on in the outpatient setting, is how often do we actually reach out, and maybe we can't physically touch that person, but how often do we talk to them on the phone? Next slide. So Dr. Del Rio and a couple of others already talked about who is higher risk, but the two big main keys are an age equal to or over 65. And then even though obesity with a BMI equal to or greater than 30 is listed as a risk factor, an independent risk factor is a BMI greater than 40. So it's independent of age, gender, and even smoking is what some studies have found. A BMI over 40 is definitely a higher risk of worsening infection, worsening comorbidities post-infection, and death. Obviously, all of these things we're aware of. If you have any problem with one organ, that can affect other things. So people with chronic diseases and people that are on immune suppression medications. Pregnancy is an issue because women who are pregnant, their immune system automatically lowers their immune response to protect the baby, but that exposes them to being more likely to contract COVID. And next slide. Dr. Del Rio and Dr. Harris talked a lot about the disproportion among our population, and so I won't go into that. Next slide. A very rare complication seen in children is multi-system inflammatory syndrome. As of last week, I have not heard of it being reported in the state of Georgia. So it is very, very rare, but just to be aware of that as primary care providers, it shares features with Kawasaki disease and toxic shock syndrome. And so it's good for us to kind of keep up with what does Kawasaki disease look like again? And these patients have persistent fevers, they have red swollen extremities, bloodshot eyes, rash. It's very alarming, and they definitely need to be seen. Next slide. So important questions to ask in the primary care setting is, when was the first day your symptoms started? And were you short of breath then, or are you short of breath now? And if you are short of breath, when did that start? Typically, patients will get a viral syndrome or prodrome first, and then they will develop shortness of breath anywhere from 2.5 days to a week afterwards. And that's when you start to get concerning, is those first couple of days that you're short of breath are the really important ones where you can decompensate, where the patient can decompensate and develop acute respiratory distress syndrome. So shortness of breath or dyspnea developed in 43% of symptomatic adults and 13% of symptomatic children. So these are not asymptomatic cases. These are patients who had headaches, fevers, body aches, things like that. Next slide. So the first important question is, when did your symptoms start? And when did shortness of breath start? And then your next important question is, how bad is your shortness of breath? Is it present when you're not coughing? Has it gotten worse over the past few days? Do you have it even when you're sitting still and resting, or when you're trying to have a conversation? And it's interesting because I've talked to patients before where they say, I'm not short of breath, but then they're having to do this when they're talking, and that's a red flag for sure. And what could you do before without difficulty that now you have to take breaks, like cooking or cleaning, things like that? Next slide. So when we define the severity, we say mild is it doesn't interfere with their daily activities. You know, if they're just doing a lot more than usual, that's when they feel a little short of breath. Moderate actually limits daily activities, can't walk up one flight of stairs, can't complete daily tasks such as cooking. Severe is when you're just sitting there and you're still short of breath. You can't complete full sentences, and it interferes with basic things like using the bathroom. Next slide. So some people go as far as to ask, should I be measuring my oxygen levels? Now, not everybody has the means to do this. Some people will do it regardless, and I tell them that's fine. If you want to buy something online and have it shipped to you, but make sure that your fingers are warm, that you're doing it twice a day. If you're feeling worse, make sure or if you see a patient in the clinic, make sure you check it when they're at rest and when they're walking. You want to know if it drops below 95% because you want to watch it more closely, but typically they don't require admission to the hospital until it's less than 90%. And just as an FYI, readings through a smartphone app are not considered accurate. Next slide. So this is just an illustration to show you what tripod breathing is, where it actually increases work of breathing. So this is earlier in the talk when I said, sometimes you need a video visit. This is part of why a video visit is important, because patients can tell you that they feel a certain way, But if you can't touch a person and listen to their lungs, it's good for you to be able to at least look at them. Are they using accessory muscles? Are they having to lean forward while they're talking to you? Do they have any cyanosis on their lips or blue turning lips? Next slide. I think most of us know this, but just to reiterate, never do a pharyngeal exam without personal protective equipment, including on children. Next slide. Frequency of follow-up depends on patients' access to resources and their severity of their disease. Next slide. So there was a lot of complicated when to do this, when to do that, when to not do this. So it's part of it is just common sense. So if they're not high risk and they have no dyspnea, they really don't need to follow up. If they're not high risk, but they have some dyspnea, you can do a telehealth visit. If they are high risk and have no dyspnea, you can do a telehealth visit. And these are patients who are already positive. Consider telehealth visits on day 4, 7, and 10 of the onset of illness, which is a lot. And I don't know very many people that are actually doing that. High risk, they need a follow-up visit 24 hours after their diagnosis. And that includes patient has nothing else except a BMI over 40. Those patients need to be checked on. Pre-existing conditions may need even more frequent telehealth visits, such as COPD, congestive heart failure, or asthma, to help see if their concomitant condition is getting worse, or if there's any differences in the two. Next slide. When to refer to the ER, some of this is common sense too, but it's good to reiterate it. If they have severe dyspnea at rest, these patients look like they're in distress. If their oxygen level is less than 90%, regardless of the severity of dyspnea. And we call these the happy hypoxics. And what we've learned in the hospital setting is if a patient is sitting there and they feel fine and they're just like, I'm great, everything's fine, and their oxygen level is 75%, we don't necessarily need to correct it. It's when they start to decline that then we need to correct it because of the disease, because of the patho behind the disease process. But happy hypoxics do tend to be patients that can decline very rapidly, which is why they need to be in the hospital. If a patient is confused, you're concerned, they're having altered mental status, or they have other signs of low perfusion, falling, orthostasis, hypotension, cyanosis, they're not peeing. For people who are not healthcare providers and are watching at home, there are 2 websites there that can help you do your own self-assessments, or primary care providers, you can send this out to your patients. If you're diagnosed positive, then here is a self-assessment to see how sick you really are and what you need to watch. Next slide. There are some patient education lists for you. UpToDate has some good ones. The CDC, the American Association of Family Physicians, the American Nursing Association, which is at nursingworld.org. And then educate your patients on infection control and self-isolation and what that means. Next slide. Symptom management is really what we have to rely the most on right now. So helping people control their fever, start with Tylenol, only go to ibuprofen or something that's not acetaminophen based if they're not responsive to acetaminophen. Self-proning is important, breathing exercises are important. Staying well hydrated is important, and that's a balancing act with our patients who are on fluid restrictions. But when you have a fever, there's no way you sweat, and there's no way to really measure how much fluid you're losing. So it's important to increase that fluid intake for patients who are on a restriction but have fevers. Coughing may if it interferes with sleep or causes a lot of discomfort, that's when you want to suppress it. Otherwise, you want to just let it take its own course. But you can look at dextromethorphan over the counter or benzonatate or Tessalon pearls as prescription. And then resting is very important during the acute phase, but then as patients recover, they need to be getting up and moving around, helping all that fluid move out. Next slide. This is an example of breathing exercises. You can always give them an incentive spirometry and tell them to do it 10 times every hour. And remember, your incentive spirometry can be set. And so if they were able to meet their goal the first day and now they can't meet that goal, it can help you see if they're having worsening disease. Breathing exercises like inhaling through the nose and then exhaling through the mouth. So pursed lip breathing while your lips are pursed, like, and then make sure that your exhale is twice as long as your inhale, and do this several times a day. And this can help kind of open up the alveoli in the lungs. Next slide. Self-proning is very important. Early in the pandemic, we were proning, or we realized we needed to prone patients in the ICU, but we're actually seeing benefit in the outpatient setting too, to teach people you need to lay on your stomach whenever you can. Lay on your side, lay on your stomach. Stomach is best. And this illustration shows you how you have the greatest lung capacity next to your back, not in the front, because you have to make room for your heart. So if you're laying on your back, part of your lungs are kind of squished from your heart, and they fill up with fluid very easily because of gravity. But if you lay on your stomach and do pursed lip breathing, that's really good too. You kind of help open up all of that. Your fluid kind of collects closer to your heart, and it doesn't get in the way of all the oxygen exchange on your back. And overall, it improves oxygen exchange overall. So next slide. Time to recovery has been variable. So mild disease, patients tend to recover in about 2 weeks. This isn't meaning that they're, whether they're contagious or not. Remember, onset of symptoms, we usually say about 10 days is when you can return to work. But severe disease, patients tend to take 3 to 6 weeks to recover. This can vary on the age, how sick they were when they were sick, if they have other chronic diseases such as heart failure. If they're still short of breath after months, we have to consider looking at other etiologies. Obviously, this disease is still new and we don't know everything about it that we would like to know, but something concerning that we're seeing is people developing other chronic diseases such as viral myocarditis that's leading to heart failure. And so patients who are still short of breath need to be evaluated for other etiologies of shortness of breath to rule those things out. Next slide. So in a survey of 292 adult outpatients, 35% had not returned to their baseline health at 14 to 21 days. Older people had more residual symptoms. So 18 to 34 years, 26% had residual symptoms, but over 50 years, 47% had more residual symptoms. And so I like how they just kind of skipped 35 to 49, but that's okay. Comorbidities, prolonged illness in all age groups. So if you already had another disease, you could predict that you were already going to have problems past 2 weeks for most people. Fatigue, shortness of breath, and headache are the most common symptoms to persist. Next slide. Just want to touch real quick on prevalence in pediatrics. Children under 18 account for 8 to 10% of confirmed cases globally. The younger the child, the more mild the symptoms in most cases. Older teen rates, so 18 to 20, they tend to be the same as adults as far as how often they get sick. And then even Dr. Del Rio pointed out that our younger people are getting sick more often right now because they're going out and not protecting themselves. Former preterm infants that are now children are higher risk. 5.6% of children tested across 26 countries had co-infections of pneumonia, influenza, and RSV. So it's important as we enter this flu season that we don't forget to cross-test, not just test for one thing, but also test for other respiratory illnesses. Next slide. COVID-19 specific therapy should not be prescribed in the ambulatory setting outside of a clinical trial. High quality data is limited. No intervention has proven efficacy for non-severe COVID-19, and there are concerns for potential toxicity in an unmonitored setting. Next slide. There is no cure. Next slide. Treatment is focused on preventing a worsening inflammatory response. So I don't have a cure, but I can help you feel better. Next slide. And I'm just going to touch base on hydroxychloroquine only because it has been such a huge talking point in the media and amongst the public. So why has it gained so much attention? Actually, let's go to the next slide real quick. No, okay, I'll go to that in a second. So it didn't work in the ICU setting. It doesn't work in the outpatient setting. The discovery trial, recovery trial, solidarity trial, and Cochrane review have looked at hydroxychloroquine. The history of hydroxychloroquine is in 2005, chloroquine was found to be effective in preventing the spread of SARS-CoV in cell culture, so a sister of the current virus that we have. But they took primate cells and infected it and then gave the primate cells chloroquine. So this was in a test tube. Hydroxychloroquine is an antimalarial drug and a disease-modifying anti-rheumatic drug. It's used to treat patients with lupus. And it's been studied multiple times going back when it was approved as a treatment for lupus in 1956. So because of how old it is, a lot of people feel very comfortable with it. A lot of patients have taken it when they've gone on trips and needed malaria and needed to be treated for malaria or protected from malaria. And it's been studied multiple times. HIV, dengue fever, you name it, it's probably been studied. And it's amazing because the initial study, when it's in a test tube, it works 95% of the time. But in vivo, in a person, it doesn't work. It hasn't been working. Next slide. Even as post-exposure prophylaxis, it hasn't worked. And patients still had the same amount of viral load even after it. There was no changes after exposure, or they had the same viral load after exposure. All right, next slide. So this is what kind of started everything. Dr. Harvey Risch is an epidemiologist, and he published an opinion piece in May talking about hydroxychloroquine and azithromycin. And his data was based on theory, like we just talked about, all the theory behind it. And his concern was that he started writing it in March and April, published it in May, and we were still kind of ramping up studies for hydroxychloroquine and remdesivir. And his concern was when you're looking on paper at remdesivir, the antiviral seemed very promising in being an actual cure for COVID-19. But he said, until we can see the data, let's please use hydroxychloroquine and azithromycin based on all these theories that works too, because patients don't have access to remdesivir, they can't afford remdesivir, no one was getting it outside of a clinical trial, and that was his request. Let's go ahead and do this. Now, he published a paper. It did not have patient data that he had used. He used it from patient data in France that was a prospective study. There was no control group, so it was just, look, these patients were given it, and most of them did fine. So we're going to assume there's a correlation. So it's a very interesting paper to read, and it started a lot of the controversy that we see. However, in all of the trials that have been published since then, comparing to a control group, comparing to a group that either got nothing or got placebo, hydroxychloroquine's actually been causing harm. And so the WHO stopped all trials June 17th. Next slide. And so why is this important when we have a random controlled trial? So we divide people into groups, and we have blinding, and we tell them you're either going to get the treatment or you're going to get a placebo or a sugar pill or whatever the placebo happens to be. Patients tend to still have a placebo effect. So for healthcare providers that have really good relationships with their patients and the patients trust them, let's say I walked into a beautiful, clean clinic and I knew this person and I trusted them, and they came to me and they had this just freshly pressed coat and this beautiful, cup with a gold pill in it, and they said, "This will cure you." I'm a lot more likely to actually respond to the treatment than I am if it's a dirty clinic, it's someone I don't know, they have a rumpled coat, they hand me a white pill and say, "Yeah, this will help you." Right? There's a big difference. So Dr. Martin Green is a neurologist who's actually done a lot of studies on placebo effect and even the provider as a placebo and how they present the information to patients. And so knowing that the more painful, like if you have an injection or a surgery, or the different color of the pill, all of these things can affect how patients respond, because we have a true neurotransmitter response. Dopamine, serotonin, oxytocin, all these things make us feel good. And so then we think, well, this must be working. We do not understand our brains and how much they impact our health like we would like to. We really don't. So people can have natural opioid responses and natural pain dampening sensations. One study that was not done in COVID, it was done in a different bronchitis study, showed that there was an 85% reduction in cough in both groups, and only 15% more reduction in the group that got the actual cough medication and not the placebo. So we had to assume that 85% of the reduction of cough was placebo. It's amazing. Here's your pill, it'll cure your cough. Oh, look, my cough is cured. So this is what's important to understand, why, we tell, everybody has been caught up in this emotional response to the pandemic. And I feel like the pandemic has especially left us very raw and sensitive. And there's been a lot of broken trust in lots of various areas. And so it's difficult when a patient has a relationship with a provider who tells them that that this thing works, and then they see someone else say, "No, that's wrong." So the key to a lot of actually what I've heard several speakers mention today is building that trusting relationship with our patients and with the public, rebuilding and healing of that trust again, because so we can explain to them, this is why in March and April and May, these people said this, and by June we realized that it was wrong, and we don't want to hurt you. And so that's why we're going with other things. And that's my spiel on placebo. All right, next slide. So dexamethasone has been, in the recovery trial, decreased mortality in patients requiring oxygen, but there was no benefit in patients that were not on oxygen, and there was actually possible harm. So remember, dexamethasone is a steroid, and steroids actually decrease the immune response. And like we had talked about, there are kind of two ways that this virus can present: the viral prodrome and then the cytokine storm, when the body starts attacking itself, and that's when we're concerned. So dexamethasone tends to stop the cytokine storm, but if you give it when there's just a viral prodrome, it can actually make them more susceptible to getting other infections. Next slide. Convalescent plasma is only being given in an inpatient setting right now. This is plasma donated from patients who've recovered from COVID and they have positive antibodies. You can give blood. I actually encourage everybody to give blood, whether you have positive antibodies or not. Criteria was revised by the FDA in April to increase the donor pool. Again, it's only being given to hospitalized patients. Next slide. So for those in the primary care setting, for patients' home meds in general, their meds should not be adjusted. I referred to ACE inhibitors earlier, and so that's what we need to go over is don't change their ACE inhibitors unless they're having something else that would cause you to think that besides COVID, like a acute kidney injury or something like that. Inhalers and nebulizers should not be used around other people. Children should be using a metered dose inhaler, and this is to keep from aerosolizing the virus and making those patients more contagious to other people. CPAP and BiPAP machines, patients who are on them for sleep apnea, they're going to have to start sleeping alone. There's the theory that it can aerosolize the virus. If they're positive for the virus and they wear a CPAP machine, if they're positive for the virus, they should probably be sleeping alone anyway. But if they're positive for the virus and they sleep with a CPAP machine, they need to not sleep with their partner. Hemodialysis patients, anytime they're having dialysis done, need to be isolated from other patients. Erythropoiesis meds in end-stage renal disease patients may need to be stopped. The theory is that they can increase thrombosis, but that's something that would have to be done, a shared decision-making in conjunction with nephrology. Immunosuppression medications should only be adjusted by the original prescriber. So if you have a transplant patient, you need to have a close relationship with their transplant team. The dose may be stopped temporarily or decreased if the patient is actually positive for COVID. Next slide. UpToDate recommends checking coagulation studies in the inpatient setting only for thromboprophylaxis. Those tests are PT, platelets, fibrinogen, and D-dimer. Abnormals determine if the patient actually needs heparin dosing and how aggressive for that to be in the hospital. In the outpatient setting, there's still not a lot of data on this, but you can consider doing a baby aspirin, and then always have a low threshold to look for developing clots, such as DVT or PE. Patients may even be asymptomatic. Post-hospital prophylaxis data is actually very limited, and so there was a study that showed COVID patients post-discharge compared to regular patients post-discharge had very similar rates of developing DVTs, but that the COVID patients tended to have their DVTs show up within the first 8 days, and the other patients tended to have it would be the first 30 days. So those first 2 weeks after discharge may be a time that you would want to talk about your patient with them taking a baby aspirin. Oh, you were in the hospital with COVID and you were on a heparin drip, and now you've been discharged off of anticoagulation, which is still being studied, and there doesn't seem to be a strong correlation that they need anticoagulation, but you might want to consider platelet inhibitors such as a baby aspirin. Next slide. If you're really uncertain, you can actually use the ISTH scoring system for DIC. And what we're doing is we're using a lot of data that already exists and applying it to COVID patients and seeing what happens. So in the hospital setting, the scoring system for DIC is being used for COVID patients. And so you're looking at platelet numbers and how many points they get, PT prolongation, fibrinogen, and D-dimer. So if you draw these labs and the patient scores 5 or greater, it's highly suggestive of DIC, but it's also highly suggestive of thrombus formation in COVID, that's their risk. And you can empirically start them on anticoagulation. Again, this is a suggestion. It is not something that has been verified in a study yet, but this is what's currently happening in the hospital, and it's being studied as how it applies in the outpatient setting too. Next slide. Azithromycin. It's actually not been shown to be helpful when given with hydroxychloroquine in current studies. It is being compared to doxycycline for concomitant infection. It is helpful in preventing co-infection. You really only want to give it when there's concern of underlying bacterial infection. Now, azithromycin is an antibiotic, a macrolide antibiotic that has some anti-inflammatory and some theoretically antiviral properties, but it is not an antiviral, it's an antibiotic. And so anytime you prescribe an antibiotic, you buy all the risks that you do with every antibiotic, and that's increasing of C. diff, increasing of fungal infections, increasing bacterial resistance, and we don't want to do that. So azithromycin really needs to be taken with a grain of salt, and there needs to be a lot of clinical decision behind prescribing azithromycin in a COVID positive patient. Next slide. UpToDate recommends that all patients diagnosed with COVID have an updated healthcare proxy and advanced directive information, which is actually very sobering. This is a very hard conversation to have, especially with younger patients. Hey, you were diagnosed with COVID. If something were to happen to you and you were on life support, you couldn't make decisions for yourself, is there a plan of care you want? Are there people you want to have that you could refer to? Things like that. Next slide. This is just a touch on side effects. Obviously, with aspirin, you can have bleeding. Azithromycin, you can have GI upset, convalescent plasma. Patients can have transfusion reactions, antibody-dependent enhancement, which is a theoretical risk of any time you give patients blood, especially blood that's full of antibodies, is that the infection will get worse, but it's a theory and it actually hasn't been seen. Dexamethasone has its own long list of side effects. And so these things we're not going to give in the outpatient setting. It's just something to think of except for maybe azithromycin and aspirin. It's not the convalescent plasma and dexamethasone we're not going to give, but it's something to think about in our post-discharge patients. Next slide. We're going to talk about supplementation. Next slide. Vitamin C right now is being researched in high dose IV form for patients who are in the ICU. However, in past data that didn't have anything to do with COVID, in previous data, deficiency of vitamin C correlates with the development of pneumonia. Taking vitamin C shortens the duration of colds, and it decreases incidence of colds in active people. It doesn't really decrease it in inactive people. And the theory is that active people have a lot more oxidative stress because of using their muscles, and inactive people don't. So vitamin C helps mitigate that oxidative stress. So it's protective. It helps like with the outer layer of host cells. It helps protect your body's own cells from breaking down when the virus or bacteria are being attacked. And animal studies showed that when animals are sick with a virus or bacterial infection, that they lose vitamin C. So there's some kind of degradation of the vitamin C during illnesses. And then current studies are showing that higher vitamin C levels actually decrease interleukin-6, which is the one of the main inflammatory markers that we see in COVID patients. Next slide. Vitamin D, there was a single center study. Vitamin D deficiency was more often seen in patients who were positive for COVID-19. So were they more, so the thought was, were they more likely to develop the infection or be prone to the infection because they had vitamin D deficiency? It's really still unclear, but not only were more COVID positive, were more patients with a COVID positive, but they were also sicker, these patients who had vitamin D deficiency. Deficiency in past studies of vitamin D has been shown to have higher associations with autoimmune disease and vitamin D helps reduce inflammatory markers. Next slide. Zinc, now this is theoretical, it's being studied right now, so I don't have any data in COVID patients. These are past studies. Blocks the virus from entering the lung, cell, and tissue, decreases viral replication in other viruses, it strengthens the immune system. Higher infection rates for other illnesses are seen in patients with zinc deficiency. Evidence suggests that if you have good levels of zinc, you have decreased clot formation. However, zinc can also cause a lot of medication reactions, so you don't want to get zinc at the same time as antibiotics. So you don't want, if you do end up prescribing azithromycin, tell them don't take the zinc tablet and the azithromycin at the same time. If they take it with a thiazide diuretic, they may increase zinc loss in the urine. And long-term use can actually cause copper deficiency. So zinc isn't something that we want to be taking high doses of all the time, thinking that it's going to keep us from getting sick forever and ever, because that can actually cause, too much of a good thing is really a bad thing. So it can actually cause copper deficiency. And then I've never seen nasal spray versions. I don't think they're available here, but they can damage our sense of smell permanently. Next slide. This is a picture of what zinc does in the body, and how there is with the zinc that's being studied in COVID right now, the zinc deficiency and the COVID-19. There's a lot of crossover. Those two circles at the top. And so how it's decreasing viral replication and then increasing immune function and being protective of the body. Next slide. Melatonin, there were some very interesting, there was at least 3 studies on melatonin that came out that were very interesting. And it showed, you can see this pathway here, how melatonin can prevent cytokine storm, how it can prevent ARDS, and how it can actually keep you from having worsening injury to the lung. It decreases oxidative stress and inflammatory markers, and so overall reduces the severity of the infection. It doesn't fight the infection, but it reduces the severity by giving all these protective factors, and also decreases levels of interleukin-6 and tumor necrosis factor. Why is this important? Because a lot of people are melatonin deficient, and a big thing that brings down our melatonin levels is blue light and looking at screens like you're doing right now. Next slide. So how do we naturally increase melatonin? We decrease exposure to blue light and artificial light, especially 30 to 60 minutes before we go to bed. Having a bedtime routine, getting lots of natural sun exposure when we can, cutting down caffeine and stress because those things reduce melatonin, making sure we're eating fresh fruits, vegetables, and nuts. Elderly do not make as much melatonin, so there's always concern with them. Do they need to be on a melatonin supplement or not? Next slide. So there are side effects to everything. And as we talked about, the symptoms of COVID can be a lot of GI distress, headache, fatigue. Those are also the symptoms of side effects of too much vitamins. So we need to have a balance. Melatonin can cause sleepiness, headache, or confusion. So that's also very concerning. You always want to start low and go slow when you're going with supplementation. What I've read is that people have said, if you do not have a proven deficiency, then you do not need a replacement. However, studies are showing that the majority of Americans are already vitamin D deficient. So you don't necessarily have to test for vitamin D deficiency unless you're concerned that they're so severely deficient that they're going to need that prescription dose of 50,000 international units a week. Next slide. So in the outpatient setting, what are we going to do? Are we going to bring our, we did the drive-by swab, they were positive, we did our little phone call, are you okay? Is there anything else left to do? Well, if you're concerned and you want to really, especially if they have comorbid conditions, Strongly recommend looking at a complete blood count with differential, because we want to look and see, do they have a high white blood cell count? Do they have a low lymphocyte count? Those can be predictors of severity of disease. Especially an elevated AST in your liver panel can predict severity of disease. LDH can also predict how the inflammatory response. When patients are inpatient, they automatically get a D-dimer, a ferritin, and a CRP level. So those aren't necessarily things you need to draw in the outpatient setting unless you're wanting to look for, unless you have high suspicion for other things going on. I put questionable interleukin-6 because that tends to be a test that takes a long time to come back. Sometimes it can take 5 to 7 days to come back, and really is only used in the inpatient setting to look at progress of disease. You definitely want to look at their chest x-ray findings. If there's somebody who has COPD or other underlying illnesses, you might want to check a chest x-ray and see how they're progressing with their disease process. And obviously vital signs are something that we pay close attention to all the time. Next slide. So this is to summarize everything we just talked about. So what's the outpatient cocktail and habits? Aspirin is still being studied, so I'm not going to just flat out say aspirin, but definitely with some shared decision making and some clinical judgment, look at aspirin. Think about your melatonin, your vitamin C, your vitamin D, and your zinc. Maybe do you need azithromycin? Maybe if they have underlying asthma or other diseases, do you need to add prednisone? Talk to your patients about breathing exercises, what self-proning looks like, what self-isolation looks like, what hygiene looks like. Tell them early in the disease process to rest. Tell them later that they need to start walking, and teach them about not using nebulized medications or their CPAP around other people. Next slide. ClinicalTrials.gov is, and I'm happy to give you a copy of my presentation, yes. ClinicalTrials.gov is where you can go to see, if you're concerned that your patient needs an antiviral, they're sick, but they're not sick enough to be in the hospital, or you have limited beds available in your local hospital, definitely trying to get your patients enrolled in a clinical trial is important. Clinical trials there are over 2,500 clinical trials going on right now across the globe. So clinicaltrials.gov looks at everything around the world. We're looking at pre-exposure prophylaxis. We're looking at mental health. We're looking at maternal fetal health. We're looking at interleukin-6 inhibitors, different antivirals besides just remdesivir. We're looking at doxycycline because we know that doxycycline kind of has this weird anti-inflammatory, antiviral effect in the body, similar to azithromycin. We're looking at different diagnostics testing, different urine studies. Does COVID show up in the urine? Different radiology studies. Early in the pandemic, when we really knew nothing, we were being told to CT scan everybody so that we could find it, and we didn't have accurate testing, and obviously now we've gotten away from that, but it's good to still look at all our radiology studies. And then you can search for ones that are actively recruiting. Iran is currently running one on the effect of donkey milk. So there you go. Next slide. COVID-induced chronic diseases is going to be something that we're going to see more and more and more of. So as you've heard earlier in the presentation when talking about cardiology especially, and this is something that cardiologists are talking a lot about, so I don't know how many people outside of cardiology world are hearing, but the concern was the huge drop in admissions to the hospital for myocardial infarctions when the stay-at-home orders were in place in the United States. And one concern was if people don't have, if they don't come in with an MI, are they still having an MI? And they were. And so what's happening is people were actually staying home and they were infarcting at home. And then when they came in, eventually, now they've been in heart failure for months because they infarcted and they didn't get it treated. We are also seeing COVID caused myocarditis. Some cases on biopsy, there's only lymphocytic proliferation in the myocardium. And then on some biopsies, there's actual COVID virus itself. So there's still a lot to learn about what's happening with congestive heart failure as far as COVID-induced chronic disease. Sorry, I'm losing my train of thought. Okay, so in 2019, 51% of patients would have a cardiac arrest at home, and the age would be close to 70. In 2020, because of the stay-at-home orders, we've seen an increase to 61% and a decrease in the age to closer to 65. Bystander CPR dropped because of either people weren't around because of stay-at-home orders, or people were afraid of getting the virus. So because of these confounding factors, that we've had a lot of chronic disease affecting our already sick cardiac patients. Chronic kidney disease, there's actually been cases of COVID-induced nephropathy versus direct infection. And so we don't know how much of that is ACE2 receptors or not. And then there's actually severe deconditioning after hospital discharge. So looking at how much home health, physical therapy, protein support, things like that, do these patients have access to food, it is very important. And I can't talk about everything because we still don't know. Next slide. So what I'm telling my patients is, you've heard stay home if you're sick, but I really need you to call me if you feel sick. I really need you to let me know if you feel sick. Don't just go, well, now I've got the COVID, and you stay home, or you go through a drive-through testing center and you don't have any follow-up. Like, I need to know your primary care providers, your specialty providers, your people that you have relationships with need to know if you're sick and how you're feeling, because we need to know how often to keep in touch with you and how to keep you from getting worse. Next slide. And that's my presentation. Does anybody have any questions? Oh, I did want to say, while people are typing, thank you, Anna, that I am beyond honored to be here representing United Advanced Practice Registered Nurses of Georgia, and am just beyond honored that the Emory-Clifton Rotary Club would partner with us for this symposium and ask us to speak. I really greatly appreciate it, and I have been just blown away at the quality of these speakers and the quality of this presentation and this symposium. This is really amazing stuff, and I really love seeing where we are with polio eradication and how we are taking what we know about polio eradication and putting it with COVID, and how, and I really have enjoyed seeing how we've talked about how important it is just building that trusting relationship with the community and addressing all other factors that affect our health, including the environment and social determinants of health. And I just really greatly appreciate that. So I will definitely share my presentation, and I really appreciate everybody today. And thank you so much. And I have references at the end of, I had a lot of references at the end of my presentation. So you will definitely be getting my presentation.
Thanks. Hey, Ashley, you actually got a question in
Okay.
the chat. Should a PT on hydrochloroquine worry if COVID positive?
So you're asking if someone like who has lupus or is on hydroxychloroquine for something else, if they should worry about becoming should they worry about becoming COVID positive, or if they're already COVID positive?
The question they didn't go into detail. Penny, if you're there, if you can kind of clarify your question in the chat. Or she's already on.
So I'll just start to answer. Okay, so someone's already on hydroxychloroquine and then they test positive. You don't change their hydroxychloroquine. The concern is that they had hydroxychloroquine isn't doing anything, but it is suppressing the immune response. So you want to watch them very closely for worsening of their disease. In theory, hydroxychloroquine makes sense. Remember in the test tube how it would decrease viral replication and decrease the immune response. But the problem is that it's not showing any help in COVID positive patients. So say it's a lupus patient and they're on hydroxychloroquine and then they become positive for COVID-19, I would just watch them very closely. I wouldn't make any changes to their medications. And if I'm the one prescribing the hydroxychloroquine, I might do some of those extra tests that we talked about and watch their LDH and watch their inflammatory factors, their markers, to see if we need to go down on the hydroxychloroquine. But it's definitely a balancing act. I'm not usually the prescriber, usually the rheumatologist is, and so I might send them to the rheumatologist for review, if that makes sense. I hope that answers your question.
Another question we got is, now that we're in flu season, I guess it's a two-part question. One, is it possible to get influenza and COVID at the same time? And what should we be doing to know the difference between the flu and COVID?
That's a great question. So what we're seeing right now in the primary care setting is actually a lower influenza rate, partly because everybody's wearing masks and washing their hands, so that's a good thing. But we're presuming that everybody's going to have everything. So we're usually testing for as many things as we possibly can. We're testing for influenza A and B, we're testing for RSV. And then if they're positive, then you go through that shared decision making of whether Tamiflu would be something that would help them or not. Tamiflu has not been shown to be helpful with coronavirus, but if they have concomitant illness, like I said earlier, they can actually have a prolonged illness course. So we want to shorten that as much as possible and help them feel better as much as possible. So you would, treat their symptoms, use supportive care, and make sure they're getting plenty of fluids, and you could talk about giving them Tamiflu.
All right, thank you, Ashley, for a wonderful presentation.
Thank you.